These practice problems will focus on what we've covered since quiz 2 to help you prepare for quiz 3. I'm going to read each question and then I'll put up the little pause icon so you can stop the video and answer the question on your own and then continue on at your own pace. In 1968, the World Health Organization published the Principles of Early Disease Detection. Before creating a screening program, you should ensure that there should be an agreed-upon policy on whom to treat as patients, there should be a recognizable latent or early symptomatic stage, the condition sought should be an important health problem, or all of the above. All of the above. Which of the following is an example of primary prevention? Educating someone considering pregnancy about folate supplementation, ordering a hemoglobin A1C on someone with a family history of diabetes, newborn hearing screening, asking an adolescent about depressed mood or anhedonia over the last 2 weeks. Educating someone considering pregnancy about folate supplementation. Remember, primary prevention refers to preventive health interventions before someone has a disease. Talking to someone considering pregnancy about folate supplementation reduces the risk that if that woman was to become pregnant, the fetus would develop spina bifida if she has a folate deficiency. So it's preventing the disease from happening before it's even started to occur. Ordering a hemoglobin A1C test because someone has a family history of diabetes is screening, which is a type of secondary prevention. If the hemoglobin A1C result was elevated, that would help you diagnose diabetes, perhaps before any complications have developed. But screening tests are catching a disease in the early stages when a disease can be treated more effectively and complications can be prevented. But screening tests are not preventing the disease from starting in the first place. They're catching it after the disease process has already begun. Newborn hearing screening is another secondary prevention intervention, as is screening for depression. The specificity of a screening test refers to the ability of a test to correctly identify the people who have the disease, the probability that someone with a positive test result has the disease, the ability of a test to correctly identify the people who do not have the disease, or the ability of a test to screen for a disease before onset of symptoms. The ability of a test to correctly identify the people who do not have the disease. Specificity is how good a test is at labeling the people as negative who are actually negative, meaning they don't have the disease. The first answer is sensitivity, the ability of a test to correctly identify the people who do have the disease, to correctly label the people as positive who are actually positive for the disease. Remember, with screening programs, we often will choose a screening test with a high sensitivity, even if that means compromising specificity, because if people test positive with a screening test, we'll bring them in and do a confirmatory test, which will have a high specificity. For most conditions, it's better to accidentally label some people as being positive for a disease to make sure everyone who might have the disease in the population comes in to get more testing. And the confirmatory test is used to weed out the people who actually don't have the disease to make a final diagnosis. Your clinic is conducting a study to assess a new screening test by comparing it to the gold standard screening test for that disease. What is the sensitivity of this test? 93%. Sensitivity is the true positives, the people who actually have the disease, who tested positive, divided by everyone with the disease. So we divide the 56 people the test correctly labeled as having the disease by all the people in the population who actually have the disease. In this example, there were 4 people who have the disease, but the test incorrectly labeled those 4 people as not having the disease. Your clinic director was so happy with your sensitivity results, they asked you to calculate the specificity for the same screening test. What is the specificity of this test? 99%. Specificity is the true negatives, the people who do not have the disease, who the test correctly labeled as not having the disease, divided by all the people who actually do not have the disease. We divide the 900 people correctly labeled as not having the disease by all of the people in the population who do not actually have the disease. So this test failed to label 9 people as not having the disease who actually don't have the disease. A higher disease prevalence will increase a screening test's sensitivity, specificity, negative predictive value, or positive predictive value. Positive predictive value. Remember that sensitivity and specificity are characteristics of the test. They don't change based on the population you're using the test for. But predictive values take into account the prevalence in the population you're testing. As the prevalence of the condition in the population increases, there will be an increase in the positive predictive value. That effect tailors off at very high prevalence, but that usually isn't relevant for human health conditions we screen for. In the positive predictive value map blog post I shared from during the COVID-19 pandemic, I gave examples of how this was impacting screening of international travelers at airports. Check that out if you haven't yet for more on this topic. You're studying the effects of cigarette smoking on heart disease. What is the attributable risk of smoking based on your data? 4%. Remember, the attributable risk for an exposed population is the risk in the exposed minus the risk in the unexposed. So we divide the smokers who have heart disease by all of the smokers minus the people with heart disease who are non-smokers, those without the exposure, out of all the people who are non-smokers to get 0.04 or 4%. Plague is an infection caused by the bacteria Yersinia pestis. Outbreaks occur every few years in some areas of the US, such as New Mexico, usually when people get bit by a flea. Incidence in rodents increases when areas become overpopulated, which has been linked to climate change such as warm winters followed by abundant food. Label each role in the epidemiologic triangle of plague. The agent is Yersinia pestis, the bacteria. Fleas are the vector for plague because they spread the agent to the host. Rats are the reservoir host, they're the normal host for plague, and humans can be considered an incidental host. Hypothetically, if there were no more humans on Earth, that wouldn't eliminate plague. Plague would still be able to continue its cycle of infecting fleas and getting spread to rats, even if humans were gone. So that's one way of thinking about an incidental host. If the incidental host were removed, the cycle of transmission would continue without us. And climate change is an environmental factor that could increase the transmission of plague because when it's warmer in the winter, more rodents survive the winter. And if it rains a lot and then a lot more plants grow, so there's more berries and other things for rodents to eat, the rodent populations increase a lot because they're able to reproduce quickly in the spring and summer months. Based on this information, plague in the southwestern US would best be classified as pandemic, epidemic, endemic, or an isolated outbreak. Endemic. While plague in humans is rare, it's typically confirmed in people in New Mexico most years, with outbreaks involving 5 to 10 people occurring every few years or so on average. Plague is always in the wild rodent populations, but human infections occur sporadically related to changes in the rodent populations, with most cases occurring in the summer each year. In 2019, there was an outbreak of lung injury associated with contaminated THC-containing vaping products, which involved several companies in all 50 states. Once the cause was identified after many people were hospitalized, public health advisories notified the users of e-cigarettes of the potential contamination and the affected products. What would you expect this epidemic curve to look like? This was most like a single exposure. If you remember reading about that when it was in the news, many different companies had gotten contaminated product and it was sold all across the US at the same time. So people were getting sick across all 50 states around the same time. But once the cause was identified, people could avoid the exposure, so cases decreased pretty quickly after that. This is the actual epidemic curve from the CDC, from that outbreak of lung injury associated with e-cigarettes. You can see how the real data isn't exactly like my simple line drawing, but it's pretty darn close. So if you were doing an outbreak investigation and that's what your histogram looks like, you could pretty accurately guess how it was spreading or what was going on with the outbreak based on the shape. You're reading about a case control study that enrolled 10,000 women with pelvic inflammatory disease and 10,000 women without pelvic inflammatory disease as controls. The researchers were interested in learning more about the effects of sexually transmitted infections such as gonorrhea and chlamydia on the long-term risks of pelvic inflammatory disease. Which measure or measures of association can be calculated from this type of study? Relative risk, odds ratio, risk ratio, or rate ratio? Odds ratio. The other measures can't be calculated from a case control study because you don't know the incidence in the population. You're enrolling 10,000 women already diagnosed with pelvic inflammatory disease and 10,000 women without pelvic inflammatory disease. So you're making an artificial population with a prevalence of 50%. You can't then use the incidence of 50% in calculations of risk. That wouldn't make any sense. But when a condition is uncommon, the odds ratio provides a good approximation of the relative risk or risk ratio. In survival analysis, such as when the treatment and control arms of a clinical trial are being compared, the blank summarizes the difference between the two groups with a single number, which indicates no difference if it's equal to 1. The probability that the difference between the two groups is due to chance is calculated using regression models and reported with a 95% confidence interval and a p-value. Is the blank risk ratio, rate ratio, odds ratio, or hazard ratio? Hazard ratio. Remember that hazard ratio is like odds ratio, but instead of being for a specified time period, it's the chance of the outcome over the course of the study. Hazard ratio is the hazard in the exposed group divided by the hazard in the unexposed group. You're planning to study cavities in children living in rural Alaska using grant funding for water and sanitation infrastructure. Do you expect odds ratio will provide an accurate estimate of the relative risk of cavities in this population? Why or why not? Select the best answer. Yes, odds ratio provides a good estimate of the relative risk when the incidence is unknown. Yes, the odds ratio will be more accurate than the relative risk because the prevalence is greater than 10%. No, odds ratios are never accurate when used for research studies on preventive health topics. No, the more common a condition is, the more the odds ratio will deviate from the relative risk. Remember in the lecture when I compared the obesity study to the thyroid cancer study? And for the thyroid cancer study, the odds ratio and the relative risk were almost exactly the same because thyroid cancer is rare. But obesity is so common that the odds ratio didn't provide a good estimate of the relative risk. Similarly, cavities in children living in rural Alaska are very common, so odds ratio would probably not provide an accurate estimate of the relative risk. What's the attack rate for sour cream? Practice calculating it for avocado and pinto beans too. Attack rate is the people who got sick with that exposure out of all the people with that exposure. So for sour cream's attack rate, we divide the 41 people who ate sour cream and got sick by the 75 people total who ate sour cream for an attack rate of 55%. For avocado, we divide 49 by the 100 people who ate avocado for an attack rate of 49%. And for pinto beans, we divide 19 by the 61 people who ate pinto beans for an attack rate of 31%. You volunteer to provide public health assistance in the Federal District of Brazil, which is in the midst of an unprecedented dengue outbreak with a prevalence of 14%. Because field hospitals are overwhelmed by the volume of dengue patients, they're using a point-of-care rapid test rather than the standard nucleic acid amplification test. What are the sensitivity and specificity of the test below? For sensitivity, we divide the people who tested positive for dengue who actually have the disease, 47, by all the people who actually have the disease. The 47 true positives and the 8 people who tested negative but actually do have the disease, the false negatives. And for specificity, we divide the people who tested negative, who in fact do not have dengue, by all the people who do not have dengue. So if you tested a population who was already confirmed to have dengue, this test would correctly label 85.5% of those people with dengue as being positive for dengue. And if you tested a population already known to definitely not have dengue, the test would correctly label 94.3% of those people as not having dengue. What proportion of real patients who test negative are actually free of disease? Remember that sensitivity and specificity are derived from a research context where everyone is already confirmed to either have the disease or not have the disease. Now we're applying the sensitivity and specificity from the research context to a real population. You can start with whatever size population you want because it wasn't provided in this example. I'm going to use 1,000 as an easy round number to work with. We know 14% of the people in our population have dengue, so we multiply 1,000 by 0.14 to find that 140 people in our population have dengue. Then we subtract 140 from 1,000 to get the people in our population who do not have dengue. Next, we use the sensitivity we calculated previously and multiply the sensitivity of 85.5 by the people who have the disease to get how many people the test would correctly label as being positive for dengue. Then we subtract 120 from 140 to get the 20 people who actually have dengue but who would test negative. Then we use the specificity and multiply by the people who do not have the disease, 860, to get the people who would test negative out of the people who really don't have the disease. Then we subtract 811 from 860 to get the people who do not have dengue who would incorrectly be labeled as positive by the test. And we can check our work in the 2x2 table by adding up the people who tested positive is 169 and 831 people would test negative, which adds to 1,000. To determine what proportion of real patients who test negative are actually free of disease, we need to calculate the negative predictive value. So we divide the people who do not have dengue who tested negative by all the people who tested negative, which gives us a negative predictive value of 97.6%. When figuring out how many people would test positive and how many people would test negative in this example, I rounded to the nearest whole number because within the 2x2 table, we're talking about people, which you can't have fractions of. A local woman approaches you in a panic because your colleague on the dengue screening team just told her she tested positive. How likely is it that she actually has dengue? Positive predictive value answers this question. We divide the true positives, the people who actually have dengue in this population, who would correctly be labeled as positive by the test, by all the people who would test positive when we're using this test in the Federal District of Brazil with a 14% dengue prevalence. So given her positive test result, there's a 71% chance she actually has dengue.